Okay, so next we're going to be discussing other extraoral imaging, and this is on chapter 23 of your dental radiography textbook. The learning objectives associated with this chapter are to define the key terms associated with extraoral imaging, the purpose and uses of extraoral imaging, the equipment used, and to detail the equipment and patient preparations necessary before exposing an extraoral projection. Also to identify the purpose and to describe the head position, the receptor placement, and the beam alignment for each of the following extraoral projections. So that's the lateral jaw projection body of the mandible, the lateral jaw projection ramus of the mandible, the lateral cephalometric projection, the posterior anterior projection, the Waters projection, the submental vertex projection, the reverse town projection, and the transcranial projection. The purpose of this chapter is to present the basic concepts of extraoral imaging and to describe the necessary patient and equipment preparations. And as discussed in chapter 22, it is not always possible to obtain adequate diagnostic information from intraoral images alone. Jaw fractures, impacted teeth, and large lesions cannot be adequately examined on intraoral projections. And in such cases, an extraoral image can be used to view large areas of the jaws and the skull. The panoramic image is not the most popular extraoral projection. The panoramic image is the most popular extraoral projection. But in specialty practices such as oral surgery and orthodontics, it's common for additional extraoral projections to be utilized. So we also want to introduce a number of extraoral projection techniques and describe the receptor placement, patient positioning, and beam alignment for such projections. As the term extraoral suggests, an extraoral receptor is one that is placed outside the mouth during the X-ray exposure. Extraoral imaging is used to view large areas of the jaws or the skull. A variety of projections are used in extraoral imaging, and the choice of the projection depends on what information is needed. The purpose and use of these types of projections are to evaluate large areas of the skull or jaws, to evaluate growth and development, impacted teeth, to detect lesions, diseases, and other conditions of the jaws, to examine the extent of large lesions, to evaluate trauma, and to evaluate the temporomandibular joint or TMJ area. So in some cases, an extraoral projection is indicated because the patient has swelling and is unable to tolerate the placement of intraoral receptors. And like the panoramic projection, as an extraoral image, it does not, like the panoramic projection, an extraoral image does not appear as defined or sharp as what is seen in an intraoral projection. So that is why extraoral imaging is not used to detect decay, periodontal disease, or periapical diseases. A standard intraoral X-ray machine may be used for some extraoral images. And to aid in positioning the patient and alignment of the X-ray beam, special head positioning and beam alignment devices can be added to the intraoral X-ray machine. Some panoramic X-ray units may also be used for obtaining extraoral projections. In such case, the panoramic X-ray tube head is used in conjunction with a special extension arm and a device known as a cephalostat or craniostat. And the cephalostat is inserted into the patient's ears, and we'll look at a picture of what that looks like in a minute. Let's see, actually we'll go to that now. So this is a picture of an Orthophos XG5 panoramic machine. And we sort of went over what this area of that machine looks like and how to use that area of the machine. But when we're talking about other types of extraoral images, we'll use this area of the machine here. And this also includes a cephalostat. And the cephalostat is this area here, these little arms. And this is inserted, these little parts are inserted into the patient's ear. And it just helps to position their head correctly into the unit. Extraoral imaging may be digital or film-based. And the dental radiographer must be familiar with both in order to work in a variety of dental practices. Most extraoral exposures are made with a screen film that is placed in a cassette with intensifying screens. And a screen film is sensitive to the light emitted from the intensifying screens. An occlusal film is a non-screen film that may be used for some extraoral images. This does not cover a large area as does an on-screen film. The screen film and intensifying screens minimize the X-ray exposure necessary to produce a diagnostic image. An intensifying screen is a device that converts X-ray energy into visible light, such that the light, in turn, exposes the screen film. As discussed in Chapter 7 and 22, calcium tungstate screens emit blue light, and rare earth screens emit green light. The film must be compatible with the light emitted from the screen. A cassette is used to hold the screen film in tight contact with the intensifying screens and to protect the film from exposure to light. This must be labeled to orient the finished image. The front side is typically constructed of plastic and the back side is usually made of metal. And the front side of the cassette must always face the patient during exposure. In film-based imaging, a grid is a device that may be used to reduce the amount of scatter radiation that reaches an extraoral film during exposure. Scatter radiation causes film fog and reduces contrast. And a grid can be used to decrease film fog and increase the contrast of the image. A grid is composed of a series of thin lead strips embedded in a material like plastic that permits the passage of the X-ray beam. The grid is placed between the patient's head and the film, and during exposure, the grid permits the passage of the X-ray beam between the lead strips. When some of the X-rays interact with the patient's tissues, scatter radiation is produced, and this scatter radiation is then directed at the grid and the film at an angle. As a result, scatter radiation is absorbed by the lead strips and does not reach the surface of the film to cause film fog. Some step-by-step procedures include first, preparing your equipment. You always want to do this before preparing your patient. Next, you want to prepare your patient and then position your patient. Also, infection control procedures must be complete before and during exposing an extraoral receptor. And if an extraoral unit is used with a cephalostat, the ear rods must be wiped with disinfectant between patients. With equipment preparation, we want to make sure that we first prepare the receptor, whether it's digital or film. If it's film, we want to place one screen film between two intensifying screens and then securely close the cassette. And then we want to choose the exposure factors And this is according to the manufacturer's recommendations for whatever type of projection that you're trying to expose. With patient preparation, we first want to briefly explain the image procedure to the patient. Then we want to place and secure a lead apron without a thyroid collar. And then we want to request that the patient remove all objects from the head and neck region that may interfere with the procedure. And once again, this will include dentures, earrings, piercings, necklaces, napkin chains, hearing aids, and hairpins. Patient positioning varies with each extraoral projection. And this is discussed in sections on specific extraoral projection techniques. So some of a variety of the projection techniques are used in extraoral imaging, and the purpose, receptor placement, head position, beam alignment, and exposure factors differ for each projection used. Extraoral projection techniques are classified by the area of interest and include lateral jaw imaging, skull imaging, and temporomandibular joint or TMJ imaging. Lateral jaw imaging is used to examine the posterior region of the mandible and is valuable for the use in children, in patients with limited jaw opening due to a fracture or swelling, and in patients who have difficulty stabilizing or tolerating intraoral receptor placement. This includes the body of the mandible and the ramus of the mandible projection. The purpose of the lateral projection body of the mandible is to evaluate impacted teeth, fractures, and lesions located in the body of the mandible. This receptor, the receptor for this is placed flat against the patient's neck and is centered over the body of the mandible, such that the receptor must also be positioned parallel with the body of the mandible. The patient must hold the receptor in position, and the head is tipped approximately 15 degrees toward the side being imaged, while the chin is extended and elevated slightly. The central ray is directed to a point just below the inferior border of the mandible on the opposite side of the receptor. So the beam is directed upward about -50 to 20 degrees and is centered on the body of the mandible. The beam must be directed perpendicular to the exposure. And the exposure factors will vary with the receptor and the equipment used. The purpose of the ramus of the mandible lateral jaw projection is to evaluate impacted third molars, large lesions, and fractures that extend into the ramus of the mandible. The receptor placement should be placed flat against the patient's cheek and is centered over the ramus of the mandible. The head should be positioned so that it's tipped 15 degrees toward the side being imaged, and the chin should be extended and elevated. The beam alignment should be positioned such that it is posterior to the third molar area or behind the third molar area, and the vertical angulation should be about 15 to 20 degrees pointed up. The exposure factors, once again, will vary with the receptor and the equipment used. And then the ramus from the angle of the mandible to the condyle should be visible in this projection. Skull imaging is used to examine the bones of the face and skull and is most often used in oral surgery and orthodontics. Most skull projections require the use of an extraoral X-ray unit and a cephalostat. The different types of projections in skull imaging include a lateral cephalometric, posterior anterior, a Waters, a cemento vertex, and a reverse town. The lateral cephalometric projection is the most common of these type of projections, and their purpose is to evaluate facial growth and development, trauma, and diseases and developmental abnormalities. Here, the receptor is placed perpendicular to the floor in a receptor holder such that the long axis of the receptor is horizontal. This is used primarily in orthodontic offices, and it's used to evaluate the bones of the face and skull, trauma, disease, and facial abnormalities. Here, the head position should be such that the left side of the patient's head is near the receptor, and the mid-sagittal plane should be perpendicular to the floor, and the Frankfurt plane should be parallel to the floor. Here, the central ray alignment should be perpendicular to the receptor. And once again, the exposure factors will vary with the type of receptor and equipment used. The purpose of the posterior anterior projection is to evaluate facial growth and developmental trauma and, facial growth and development, trauma, and diseases with developmental abnormalities. Once again, with here, the placement of the receptor is placed perpendicular to the floor in a receptor holder, and the long axis of the receptor should be horizontal. The head should be positioned such that the forehead and nose touch the receptor. The mid-sagittal plane should be perpendicular to the floor, and the Frankfurt plane should be parallel to the floor. Here, the beam alignment of the central ray should be perpendicular to the receptor. And once again, the exposure factors with this type of projection will vary with the receptor and the equipment used. The purpose of the Waters projection is to evaluate the maxillary sinus area. Here, once again, the receptor is placed perpendicular to the floor in a receptor holder, and this time the long axis of the receptor is vertical. The head should be positioned such that the chin touches the receptor, and the tip of the nose should be about 1/2 inch to 1 inch from the receptor. Also, the mid-sagittal plane should be perpendicular to the floor. This projection also demonstrates the frontal and ethmoid sinuses, the orbits, and the nasal cavity. For the Waters projection, the beam alignment should be centered through the center of the head and perpendicular to the receptor. Once again, the exposure factors will vary with the receptor and the equipment used. The purpose of the submento vertex projection is to identify the position of the condyles and to demonstrate the base of the skull, as well as evaluate fractures that could be present in the zygomatic arch. Here, the receptor should be placed perpendicular to the floor, and the long axis should be vertical. The head should be positioned such that it is tipped slightly back, and the top of the head should still touch the receptor. The mid-sagittal plane and the Frankfurt plane should both be perpendicular to the floor. The beam alignment of the central ray should go through the center of the head and perpendicular to the receptor. Here, the exposure factors will vary according to the receptor and equipment used. And if it's a zygomatic arch that is the area of interest, the exposure time is usually reduced to approximately 1/3 of the normal exposure time that is usually required for a submento vertex projection. A reverse town projection is an image that is used to identify fractures of the condylar neck and ramus area. The receptor placement in this case is placed perpendicular to the floor, and the long axis should be vertical. The head should be positioned so that it's slightly tipped down, and the mouth should be open as wide as possible. the top of the forehead should touch the receptor, and the mid-sagittal plane should be perpendicular, and the mid-sagittal plane should be perpendicular to the floor. The beam alignment for the central ray should go through the center of the head and perpendicular to the receptor. Exposure factors will vary, once again, with the type of receptor and the equipment used. Temporal mandibular joint imaging, or TMJ imaging, is used to, it will include, well, the temporal mandibular joint includes the temporal bone and the mandible. And also the glenoid fossa and the articular eminence of the temporal bone, the condyle of the mandible, and the articular disc between the bones that is what makes up the TMJ area. The TMJ joint imaging includes transcranial projection and a temporal mandibular joint tomography. The purpose of the transcranial projection is to evaluate the superior surface of the condyle and the articular eminence. So it looks at the top portion of the condyle and the part of the condyle that articulates with the upper jaw. Here, the receptor placement is placed flat against the patient ear, and it should be centered over the TMJ. This projection can also be used to evaluate the movement of the condyle when the mouth is opened and to compare the joint spaces. With the transcranial projection, the head should be placed such that the mid-sagittal plane is perpendicular to the floor and parallel with the receptor. The beam should be aligned 2 inches above and about a ½ inch behind the ear canal opening. The vertical angulation should be positive 25 degrees. So we'll aim it 25 degrees downward. And the horizontal angulation should be forward 20 degrees. So we'll rotate the beam forward or mesially 20 degrees. Temporal mandibular joint tomography is used to examine the TMJ. Tomography, as defined in Chapter 22, is a technique used to show structures located within a selected plane of tissue while blurring structures outside the selected plane. In TMJ tomography, this is accomplished by moving the receptor and the X-ray tube in opposite directions around a fixed rotation point. The location of this rotation point determines what plane of the head will be imaged. TMJ tomography provides imaging of the bony components of the TMJ, and as a result, the condyle, the articular eminence, and the glenoid fossa can be examined on an image known as the tomogram. In addition, the tomogram can be used to estimate joint space and evaluate the extent of movement of the condyle when the mouth is open. That's it for this chapter. As always, if you have any questions, please feel free to email me, or if not, ask me in class and we will go over it then. Thanks for listening, and we'll talk next time.